Hi, my name is Karen Allison, and I'm from the University of Rochester, and I'm a glaucoma specialist.
Please tell us what you presented here at ARVO.
I'm the keynote speaker for the Weaver conference, and I'm also presenting on glaucoma treatment models comparing cataract versus cataract and MIGS.
What aspects of glaucoma are you researching in your lab?
So my journey in glaucoma research started with just studying the epidemiology of glaucoma to see who is most affected by the disease, and from that it caused me to look into other areas of the disease, such as the prevalence, the treatment methodologies, and finally clinical trials. And what I found was that even though minorities are represented most significantly with glaucoma, blacks being 6 times more affected by the disease and Hispanic 4 times more affected by the disease, with the clinical trials, they weren't represented in that way. So the treatment trials really reflected about 70% were Caucasians, about 16% was blacks, and about 3 or 4% was Hispanic, and the others were covered. And no matter where I looked, whether it was in the U.S. or in the Caribbean or in Latin America or in Asia, that the numbers stood out to me. So for a disease that's affecting primarily, causing blindness in primarily patients of color, I think that they should have been represented more highly in the studies that were done, because we don't know how effective these treatments are. And blacks are 7 times more likely to go blind from glaucoma. So a lot of the work I've been doing is looking into these areas to see how we can improve care, how we can increase diversity in the clinical trials, diversity in the physician that are treating, and in essence in making sure that we have better outcome with our patients.
What can be done to diversify clinical trials and encourage inclusivity?
So one of the problems is with these clinical trials is that a lot of whether it's pharmaceutical or whether it's industrial related or by whatever company is studying doing the trials, a lot of times they go to the same individuals to do the trials, and because of that, a lot of the same patients are being used. So what we're trying to propose is to go into areas where there's a high minority population, and therefore used physicians that are familiar with the population, physicians of color, whether they're blacks, Hispanic, whatever community you're reaching out to therefore be able to attract more patients of color into these studies. Now, there are a lot of barriers to participation in clinical trials, and one of the main ones is trust. A lot of underrepresented minorities do not trust the system with these clinical trials. So I think what we have to do is actually start creating trust with the community by going into the community, by having people running the trials that look like the people that we're trying to study, and by educating them and show empathy, show that we really care, and explain to them what these studies will help to do. And I think if we do some of those things, it will definitely improve their response and their participation.
Let's talk about the possible genetic link between glaucoma and macular degeneration.
So there is a proposed relationship with glaucoma, macular degeneration, Alzheimer's, a lot of these chronic diseases. This is in studies right now, so there's really no clear-cut way to say how it's related, but right now we're doing studies to show what the relationship is. We know it's related, but we're not sure how. For example, in low tension glaucoma, a lot of vascular abnormalities are related to it, such as migraines, and we think that there is also a relationship with certain types of cerebrovascular type diseases, and we also believe that a lot of patients that do have glaucoma also have macular degeneration and also have Alzheimer's. So the relationship we're actually in the process of studying, but as far as a conclusion, we're not there yet.
What do you think is the best way to get more people involved in clinical trials and to keep them involved in the treatment protocol?
So I think the first thing is for physicians to reach out to the community. So I believe in community population medicine, community activation. You have to get into the community in order for the community to start trusting you. Once you get into the community, then you can create a relationship, and then by educating the population, then they will be more apt to be involved in these studies. A lot of barriers, including not only trust, but including comorbidities, are big factors. Sometimes these patients cannot take off from work. There's a socioeconomic process to this also. And we don't have enough physicians, minority physicians, and not only Black, but Hispanic, to be involved in a lot of these trials. And a lot of times these manufacturers do not approach minority physicians to educate them, to train them on how to do this research. So I think before we can start doing a lot of this research, we have to have training of our physicians. We have to have community outreach, and then once that's done, then we can start doing a lot of these trials. And hopefully, if some of the restrictions and the comorbidities are reduced, then we can have more patients of color, because a lot of these patients have multiple medical problems, and these are the same patients that you're going to be using these medications to treat. So if the results that we're getting is not accurate, because we don't know how they're going to respond when they're being treated for all these other medical problems. Now, the consensus is, okay, fine, once you get the drug approved, then you can go ahead and start running trials with these patients that have multiple comorbidities. But I don't think that's fair, because the medication is already approved, you're treating the patients with them, so how do you know what the results is?
How would you suggest for physicians to seek training or get involved in clinical trials with their patients?
Well, I think the industries should reach out to physicians. The universities can start training. The NIH these are organizations that can start reaching out to minorities. And the other issue is supporting them with these studies, because we can do our own studies, but we also need money. It's very difficult to get some of these grants. These grants are going to certain organizations and not to others. So it's very difficult the burden is on a lot of these doctors to participate in a lot of these grant processes. So I think they should try to make it a lot easier and a lot more inclusive, so that many doctors can apply for these grants, minority doctors that are actually willing to work with their population, because patients want to go to people that look like them and people that understand their culture. And if you're outside of an area and you're looking in, it's very difficult for some of these patients to respond to you the way that you want them to. So, but if you can go in there and create a relationship, then I think it will be a lot easier.
Tell us about the outreach program you participate in through the University of Rochester.
I'm on the population medicine department, and we do a lot of work with glaucoma, diabetes, macular degeneration, but mostly glaucoma and diabetes as of now. The macular degeneration and the we're starting to do some work with other geneticists with macular degeneration and Alzheimer's. But now we're mostly outreaching to the community to see what the prevalence of diseases are in our community, to see how we can increase outreach and prevent blindness. But we have to realize that the population is aging and the population is also becoming more diverse. And it's estimated that by 2040, there's going to be over 112 million people with the disease of glaucoma, and over 5.9 million will be bilaterally blind. So it's a public health issue. There's a lot of risk factors for glaucoma. Some of them cannot be changed, like your race, your ethnicity, your corneal thickness, your myopia, that's becoming an epidemic, and these are all risk factors for glaucoma. So we have to prepare to find a way to treat these patients, especially increase in patients of color, because that's where the population is going in this country, and try to see how we can prevent a lot of these patients from going blind, and with all the problems of blindness. And another issue is we can also increase the amount of physicians that we train that are minorities, whether it's Hispanic, whether it's Black or Native Americans, so that they can go in and help their communities. And less than 2% of our medical school and ophthalmology residents are minorities, and that is a big problem, because looking forward to 2040, we are going to have an issue.
What is the best way for someone to reach you if they wanted to support your research and outreach projects, have questions, or want to get involved in your projects?
University of Rochester, which is Karen_Allison at urmc.rochester.edu.
What direction would you like to see the clinical trial process take in the future?
I think we're going in the right direction, but I just think we just have so much work to do. And I think empathy is a good way to start, by understanding that the population is changing and we have to have empathy towards everyone, and therefore realize that having good health care for one is having good health care for all.
Thank you for such a frank discussion on today's challenges in clinical trials. We appreciate your time.
You're welcome. Thank you.